See this, how the things start. This was yesterday's news. तो सबको समझना चाहिए कि डायबिटीज़ के अलावा अगर किसी पेशेंट को कोई इरेक्टाइल डिसफंक्शन हो तो ही शुड गो टू ए कार्डियोलॉजिस्ट एंड सी वेयर इज़ द प्रॉब्लम, व्हाट इज़ द प्रॉब्लम. टू माय लेफ्ट इज़ डॉक्टर विवेका कुमार. He is a very eminent interventional cardiologist. Viveka, you do so many interventional procedures for last so many years. I just like to ask you a very simple and straightforward question. And please tell it to the masses. In what way the heart attack is different in men and women, young and old, diabetic and non-diabetic, and the patient population which has got associated significant comorbidities. Just describe, because you have seen the coronaries very clearly, very vividly. So आपका विचार क्या है इसके बारे में? We want to have your opinion. Dr. Viveka sir.
Yes, Dr. Chopra. So first of all, let me emphasize the same fact with the other co-panelists have said, is that it's not a disease of elderly population alone. In India, where if you look at the population data, demographic data have suggested that almost 60% or more than that population is in the age group of youth, which is less than 45 years of age. And unfortunately, we are seeing an expanding incidence of acute heart attack. So in younger population, we see that the first presentation is heart attack. That is very unfortunate, and they do not fall in the umbrella what Dr. Kasliwal said of preventive health check. They feel that probably after 40 years or 45 years they would go for preventive health check. So first I would quote a study which is Swedish and Japanese study which was published last week, which said that the aging changes in developing world and specifically in Indians is 20 years earlier. So that study said that at the age of 58 to 60, whatever the changes in vascularity is there in Indian population is comparable to the changes which is there at the age of 78 in those populations. So you can imagine that it is not just by birth, but it is also because the environmental factors, so what we eat, what we do, and what stress we have on the society and the pollution, probably everything is cumulative. Coming to the difference in arteries when we treat young people compared to the older people, in younger population, I had last night one patient who was 22 years of age, was son of a councillor in South Delhi Municipal Corporation, and then that gentleman came with severe chest pain. He couldn't believe that it will be heart attack, but this pain was so severe that he reached to us within 1 hour, and there was when his main artery LED from the origin was 100% occluded. We removed the clot and there was hardly any cholesterol blockage. So we did not have to put stent. It was just sheer thrombus, clot sitting in that. And then we kept on asking the risk factor. The only risk factor was that he was chain smoker. So you can imagine that in an environment, the pollution is equivalent to 15 cigarettes a day for everybody. Then on top of that, if somebody is topping up with smoking, then definitely they are at a higher risk. So in younger population, we don't see much of atherosclerosis. It is clot formation in C2 with a mild blockages or furring of the arteries. Vis-a-vis when we look at the older population, they would have multiple blockages, and one of them has caused 100% occlusion, where you need to prepare the bed, you have to do a good balloon dilatation and then put a stent. So coming to the second presentation is that younger people tolerate the heart attack very well. So that is why they would present to us, after 12 hours, 16 hours, maybe third day, when they get a heart, failure symptoms, breathlessness, and they feel, and even their GPs would encourage them. And very importantly, we have been seeing increasingly more common that the female colleagues, they are getting more heart attack, and that is, the hormones which protect them up to the age, premenopausal age group, is being countered by the other risk factors, stress of work, the stress of, pollution, the smoking is quite prevalent in females now. So I think But despite all these, the presentation in female patient is always atypical, which Dr. Vinod Sharma said, that they would have undue fatigue. They don't really say that I have chest pain. They will feel, they come to and say that, doc, something is going wrong, and I don't think, and they attribute it to, some of the other social pressure or the workload at home or workload at the office. But if you look at, so one of my patients said that, and I take a cue from that if you are feeling something terribly abnormal which you have never ever faced in your life, any symptoms above umbilicus and undue fatigue, please get an ECG and get the opinion of a physician who has got cardiology interest, and that should be done at the earliest so that you don't lose the precious time. As you rightly said, Dr. Chopra, that first 3 hours are the golden hours, and then it should be utilized, and earlier you treat, the lesser the heart muscle will be damaged. And the other thing which I have seen paradigm shift in our practice now is the powerful fibrin specific thrombolytic therapies have come. So now we encourage, so initially we used to get called that, look doctor, we are in a peripheral center, we are getting an heart attack, and doctor here has diagnosed, we want to come and it will take at least 2 and 3 hours. Now we say that, okay, get a thrombolytic therapy, fibrin specific tenecteplase injection, and then you come. So now we have moved more in direction of what we call pharmaco-invasive strategy, where we tell the patients that you get the clot busting agent intravenously. We have got our own ambulance services where in advanced life care support ambulance these can be given, and the health personnel can supervise, but they can get it done in the local hospitals, and then they come. And in our study, where we have studies almost in last 3 years, more than 100 patients, where it has been seen that 30% of patients who received these clot busting agent did not need any stent or anything further. So that's quite revolutionary. I think by this strategy we can increase the umbrella of effective treatment of heart attack, and it is, if you look at the data, it is as good as primary PTCA. So I think the direction of treatment of heart attack is moving in this direction. And the other thing which is most important and lacking is what we call secondary prophylaxis. So if you look at some person who gets an heart attack, gets effectively treated, goes back to normal life, you should not say that the chapter is closed. He is more vulnerable, and people stop after 6 months or 1 year. We see that they stop the blood thinners, they stop the cholesterol medicine, statins and all, and they come back with the repeat heart attack. So the emphasis should be that once a heart patient, you are always a heart patient, and you have to have secondary prophylaxis. If lifestyle modification and the medications are the key, so if that is there, then the second attack will be lesser. And most importantly, and that is the theme of this panel discussion also, attack the heart attack. And as you rightly said, that unless we involve the population at large, the healthcare givers at large, and the education of the society, that heart attack is a biggest killer on this planet, and especially in this part of the world. And unless the awareness about the symptoms, about the treatment, because this is not one of the disease where you can sit and take 1 month to decide where to go, whom to be treated by. So the availability of immediate diagnosis and treatment has to be there in the community at large, and then only this menace can be countered.
I think it's very important. Dr. Viveka Kumar has given a very clear-cut and lucid distinction between the young hypertensives and elderly hypertensives. One important message is very clear from the example of one of his patients. The people who are smokers, they get only thrombus burden. They don't have plaque. And they get highly effective tenecteplase injection given. The dissolution of the clot is clear and the vessel become very clean. And he mentioned one thing more, 30% of patient may not need even angioplasty. I think the message is very clear. So we have to understand which patient should be given what at what time. I think we are going to discuss in the second component of our discussion. But a very important message is that women have a different mode of presentation. And I think he was focusing and emphasizing on Dr. Vinod Sharma, what he has pointed out. I think this is very, very important, that they are little different as compared to a men. And he also mentioned that people who come in the elderly age group, they have all kind of comorbidities. Some of them have an underlying occult or overt kidney problem. They may have a lung problem. They may have hypertension, diabetes, and associated comorbidities in the form of cancer, treated with cancer. And he also mentioned that one's heart attack does not mean you uprooted the disease. You have to have an awareness for prevention of a second heart attack, and we should not leave the medicines because they are also vulnerable. He has all those kind of patients who come to us, who come to him, attack after heart attack. So I think it's very important, those messages should be known to each and every one of you.
I think one of the simple explanation is it is a lifestyle related disease. We all know that these are lifestyle related diseases. What is lifestyle? Lifestyle means